Okay, this voiceover PowerPoint will take you no more than 20-ish minutes to listen to. The main focus is hypertension in review. There are several questions on hypertension and hypertension medications on the exam. And then the last about 6 slides is on hypertension crisis. This is considered new material for Block 4. Hypertension or high blood pressure is one of the most important modifiable risk factors that can lead to the development of cardiovascular disease. As blood pressure increases, so does the risk of myocardial infarctions or MIs, heart failure, stroke, and renal disease. Heart disease, often directly related to hypertension, accounts for 23.7% of all deaths each year in the United States. Healthy People 2020 lists the number of adults with hypertension whose blood pressure is under control as one of the 26 high priority leading health indicators for the coming decade. The National Health and Nutrition Examination Survey tracks prevention, treatment, and control of hypertension. Data from the National Health and Nutrition Exam Survey show that 83% of people 20 years of age and older with hypertension were aware that they had high blood pressure. Of these people, 76% were treated. Of those aware of their hypertension, 48% did not currently have their blood pressure well controlled. The American College of Cardiology Foundation and American Heart Association provide performance measures for hypertension management that address not only treatment but also control of blood pressure to target goals. These numbers should be a little bit of a review. Your blood pressure is equal to your cardiac output times your systemic vascular resistance. Blood pressure is the force exerted by the blood against the walls of the blood vessel. It's primarily a function of cardiac output and the systemic vascular resistance. Remember, cardiac output is the total blood flow through the systemic or pulmonary circulation per minute. Systemic vascular resistance is the force opposing the movement of blood within the blood vessel. The radius of the small arteries and arterioles is the principal factor determining the systemic vascular resistance. Blood pressure must be adequate to maintain tissue perfusion, not only during activity, but also at rest. The maintenance of normal blood pressure and tissue perfusion requires the integration of both the systemic factors and the local peripheral vascular effects. The mechanisms to regulate blood pressure can affect either cardiac output or the systemic vascular resistance or both. Regulation of blood pressure is a complex process involving both short-term and long-term mechanisms. Short-term mechanisms include the sympathetic nervous system and vascular endothelium, and that only lasts a few seconds to hours. Long-term mechanism includes renal and hormonal processes that regulate arterial resistance to the blood volume. This can last days to weeks. This table here can be found in your Lewis book. It defines hypertension, pre-hypertension, and isolated systolic hypertension, hypertension in stage 1 or stage 2. These ranges, you'll see they vary from book to book, but 120/80 is kind of the standard for normal blood pressure. This slide here goes over risk factors for primary hypertension. With age, your systolic blood pressure slowly and progressively increases, although your diastolic blood pressure will slowly and over time decrease with age. These other things I think are pretty common sense in review of hypertension. Alcohol use and tobacco use can increase your risk not only for hypertension but for cardiovascular disease. Diabetes, if you think of the pathophysiology and the narrowing of the vessels in relation to diabetes, you can probably see how that can correlate with hypertension as well. Increased lipid levels, excessive sodium in your diet. Hypertension is more prevalent in men. in young adulthood and middle age, early middle age, but after the age of 64, hypertension is more prevalent in women. Risk factors for primary hypertension also include family history, history of close blood relatives or like parents and siblings with hypertension is associated with increased risk for developing hypertension. Obesity or weight gain, ethnicity, incidence of hypertension is 2 times higher in African Americans than Caucasians. Sedentary lifestyle, socioeconomic status, and stress. Hypertension is often called the silent killer because it's frequently non-symptomatic or asymptomatic until it becomes severe and it targets organ disease and target organ disease occurs. A patient with severe hypertension may experience a variety of symptoms. The symptoms can include fatigue, dizziness, palpitations, angina, or dyspnea. In the past, symptoms of hypertension were thought to include headaches and nosebleed. Unless the blood pressure is very high, these symptoms are more frequent in people with hypertension than in the general population. However, patients with hypertension crisis may experience severe headaches, dyspnea, anxiety, and nosebleeds. The most common complications of hypertension are target organ diseases occurring in the heart, brain, peripheral vessels, kidneys, and eyes. The top picture here is a picture of a heart that demonstrates compensatory hypertrophy of the left ventricle muscle. Its constant pump against the systemic vascular resistance that was caused by hypertension. The second one is an example of cellular adaptation to an increased cardiac workload. I think these items here are pretty self-explanatory as far as diagnostic studies when it comes to hypertension. The most accurate or the most reliable is an actual measurement of the blood pressure. These other studies will let you know if there's been any extended or potential risks for other organs in the body affected by long-term hypertension. The last two I want to focus on are the ECG and the echocardiogram. We talked about ECGs or 12-lead EKGs being diagnostic by nature. It can identify the presence of left ventricular hypertrophy, cardiac ischemia, or a previous MI. Remember, this is the electrical picture of the heart. If left ventricular hypertrophy is suspected, then an echocardiography is often performed. If diagnosed with hypertension, modifiable lifestyle changes would be recommended. Overweight persons have increased incidence of hypertension and have an increased risk for cardiovascular disease. So weight reduction has a significant effect on lowering the blood pressure for many people. Weight loss of 22 pounds or 10 kilograms may decrease your systolic blood pressure by approximately 5 to 20 decimals. When person decreases their caloric intake, their sodium and fat intake, they usually also reduce their risk for cardiovascular disease and for high blood pressure. Weight reduction through a combination of calorie restriction and moderate physical activity is recommended for overweight patients with hypertension. We have talked, or you've talked about the DASH diet. DASH is recommended for anyone that has high blood pressure. Increasing fruits and vegetables and decreasing fat intake and having a more well-balanced diet with less processed foods is what's recommended. Another lifestyle modification is to restrict your sodium intake from your diet. This table here kind of tells you for a healthy adult how much sodium to restrict in your diet, and then also those with other comorbidities or other risk factors, including African Americans and middle-aged or older people, or those with a diagnosis of hypertension, diabetes, or chronic renal disease. Also, moderating your alcohol intake. Excessive alcohol intake is strongly associated with hypertension. Drinking 3 or more alcoholic beverages daily also increases your risk for cardiovascular disease and for stroke. Excess alcohol intake that results in cirrhosis is the most frequent cause of secondary hypertension. More of the lifestyle modifications. Increasing physical activity is helps promote good health. And again, this isn't excessive. This is moderate intensity of aerobic activity, at least 30 minutes most days of the week. So that could just be a 30-minute walk. Vigorous or intense aerobic activity, at least 20 minutes for 3 days a week, or muscle strengthening. For those of you that are exercise gurus, the most beneficial for someone with hypertension or with weight issues or any kind of cardiac disease is just a good regular walk, not a stroll, but a brisk walk. For adults ages 18 to 65, walking briskly at a pace that noticeably increases the pulse defines moderate intensity aerobic activity. No need for jogging or running unless you like to do that, but usually when starting off, walking is the easiest thing to recommend for someone to do. This picture is a little bit hard to see, but drug therapy. So if you're borderline high blood pressure, first the doctor is going to try to, when they first meet with you, they're going to recommend some modifiable risk factors and give you the opportunity to make necessary changes to improve your blood pressure before starting drug therapy. If you see the doctor and your blood pressure is through the roof, there may not be an option or time to try to do some of those modifiable risk factors. You may need to be put on blood pressure medication and then change some of those risk factors and see if you can be weaned off the blood pressure medication. Blood pressure medications sometimes have diuretics or like a thiazide medication associated with them. Hydrochlorothiazide is the most common. What other ones? There can be medications that have direct vasodilation, calcium channel blockers, ACE inhibitors. Remember the ACE inhibitors oftentimes you can develop a dry cough. That's one of the side effects that can happen with taking an ACE inhibitor. Specifically for male, any of these drugs, even hypertension itself, but especially the drug therapies, can cause erectile dysfunction in men. So there's I guess a little motivation to try some of those modifiable risk factors as opposed to just starting drug therapy right away. Again, that's not a reason not to take the medication. It's better to have some erectile dysfunction than to have a stroke or something serious happen. Again, this slide is going over some teaching that you would do with your patients in regards to drug therapy. Always have follow-up care to teach them about taking their blood pressure at home regularly so that they can keep track of it, take their medications regularly, but also let them know about some of the side effects. Educate them on orthostatic hypotension to make position changes slowly or just to be aware that that can happen, sexual dysfunction, dry mouth, and frequent urination, specifically because the improved circulatory and sometimes with the diuretics, with the blood pressure medications, but better heart function, some of that water retention that they sometimes can have with hypertension will start to be released. So that's why the frequent urination. Okay, so hypertension crisis is a term used to indicate either hypertension urgency or emergency. Hypertension crisis occurs at the systolic blood pressure when it's greater than 180 and or if the diastolic blood pressure is greater than 110. Blood pressure can often be greater than 220s over 140s. The difference between hypertension urgency and emergency is the absence or presence of target organ damage. Hypertension urgency develops over hours to days and does not have clinical evidence of target organ disease. It may not require hospitalization to correct, whereas hypertension emergency does have target organ disease, most often require hospitalization for prompt controlled reduction of blood pressure. If prompt treatment is not obtained, a hypertensive emergency can produce severe problems. These include encephalopathy, intracranial or subarachnoid hemorrhage, heart failure, myocardial infarct, renal failure, dissecting aortic aneurysms, or retinopathy. The rate of increase of blood pressures is more important than the absolute value of determining the need for emergency treatment. A lot of times these patients that come in, research is showing the most beneficial or therapeutic way to manage it is oral antihypertensives, although oftentimes these patients come in through the emergency room and they're put on a cardiac telemetry floor or even a step-down ICU unit, sometimes in an ICU unit. The goal is to slowly lower their heart rate. I talked about this in class a little bit about the force. If you think of that increased cardiac output with hypertension, the force, kind of like a garden hose or like a fire hose, that intense pressure. And if we drop the blood pressure too quickly, then they will have just barely a stream and your organs can actually suffer from that immediate decrease in force or blood flow. So these patients are closely monitored, and our goal is for slow and steady reduction of blood pressure. Hypertensive emergency is often manifested as hypertensive encephalopathy, a syndrome in which sudden rise in blood pressure is associated with severe headaches, nausea, vomiting, seizures, confusion, and coma. The manifestations of encephalopathy are the result of increased cerebral capillary permeability. This leads to cerebral edema and a disruption in cerebral function. On retinal examination, exudates, hemorrhages, or papillary edema are found. Renal insufficiency ranging from minor to complete renal failure can occur. Rapid cardiac decompensation ranging from unstable angina to MI and pulmonary edema is also possible. Patients can have chest pain and dyspnea. Aortic dissection can develop and will cause sudden excruciating chest and back pain and possibly reduced or absent pulses in the extremities. Patient's assessment is extremely important. Monitor for signs of neurological deficits, retinal damage, heart failure, pulmonary edema, and renal failure. The neurological changes are often similar to those related to a stroke. However, a hypertension crisis does not show focal or lateralizing signs often seen with a stroke. Okay, so this slide here talks about the hospitalized patient during a hypertensive emergency. Remember, hypertension urgency can often be managed at home or with your doctor in the doctor's office, but a hypertensive emergency does require hospitalization. I know that I said research shows that oral medications are better at maintaining blood pressure. According to Lewis, from the time this book was written, that's not the case. IV therapy is the preferred choice of medication. IV administration of antihypertensive drugs and intense care monitoring. Blood pressure level alone is a poor marker for the seriousness of the patient's condition. It is not the major factor in deciding the treatment for hypertensive crisis. The link between elevated blood pressure and signs of new progressive target organ disease determines the seriousness of the situation. When treating hypertensive emergencies, the mean arterial pressure, or the MAP, is often used instead of blood pressure readings to guide and evaluate drug therapy. The initial goal is to decrease MAP by no more than 20 to 25%, or to decrease MAP to 110 to 115. If the patient is clinically stable, drugs can be titrated to gradually lower the blood pressure over a 24-hour period. Lowering the blood pressure too quickly or too much may decrease cerebral, coronary, or renal perfusion. This can cause a stroke, a myocardial infarct, or even renal failure. Antihypertensive drugs administered IV have a rapid, within seconds to minutes, onset of action. Assess the patient's blood pressure and heart rate every 2 to 3 minutes during the initial administration of these drugs. Use an intra-arterial line or automated non-invasive blood pressure machine to monitor the blood pressure. Titrate the drug according to the MAP or BP as ordered. If you have a patient who's receiving this treatment and you have to use a blood pressure cuff, remember that you may need to check their arm frequently. If their blood pressures are super high, you can imagine how tight that cuff will get. and it can actually cause vascular damage and can cause bruising to their arm. Monitor their ECG for dysrhythmias or signs of ischemia or myocardial infarct. Measure urinary output for their renal perfusion. Patients receiving IV antihypertensives may be restricted to bed because getting up and moving around may cause cerebral ischemia or fainting. Frequent neurological checks are very important with these patients. Once the hypertension crisis is resolved, it's important to determine the cause. The patient will need appropriate management and teaching to avoid future crisis.